Welcome to Seniority Authority, the podcast where I track down experts to answer your questions on aging. I'm your host, Kathleen Toomey. Let's get smarter about growing older. Does it seem like every day there's a new health recommendation? Don't drink coffee, take aspirin. Don't take aspirin, drink coffee. Drink wine, but only red. It can get confusing, and one of the goals of Seniority Authority is to track down the experts who have the answers. Welcome to Seniority Authority. I'm your host, Kathleen Toomey. Today, we are so lucky to have Dr. Michael Berry, the Vice Chair of the U.S. Preventative Services Task Force, on the show to share the latest recommendations with us. Dr. Berry is Director of the Informed Medical Decisions Program in the Health Decision Sciences Center at Massachusetts General Hospital. He teaches medicine at Harvard Medical School and is a clinician at Mass General Hospital. Thanks to our show sponsor, the Riverwoods Group, Northern New England's largest family of nonprofit retirement communities, where active adults find community, purpose, and peace of mind. Visit riverwoodsgroup.org. Now let's hear from today's guest. Welcome to Seniority Authority, Dr. Berry.
Thanks, Kathleen. Good to be with you today.
Nice to have you, being right next door in Massachusetts.
Indeed.
The task force has been around for decades, primarily directed towards helping practitioners. Can you tell us why it's important to have a group that is completely focused on prevention?
Sure. There are lots of groups, professional societies, other expert groups that deal with the management of diseases once they happen. But having a group that makes evidence-based recommendations about preventive care, catching those diseases before they happen, is something that's important to improve the health of everyone nationwide. And that's our mission.
That's terrific. And I think most people don't realize this task force is available, but they are. And this spring, you just came out with a new recommendation on aspirin. Can you tell us about that?
Certainly. And in fact, this is revisiting a recommendation on aspirin that we've made before. There was considerable new evidence, and the way the task force works is we marshal the evidence from research studies, review it carefully, and see if recommendations need to be revised or made if we're dealing with a new one. And aspirin is a good case in point because there's been considerable research in recent years on both the benefits and harms of taking aspirin to prevent cardiovascular diseases, particularly heart attacks and strokes. And we have two recommendations that are simply stratified by age for people age 40 to 59 who have a greater than 10% risk of having a heart attack or stroke over the next 10 years. And there are ways to estimate that. We recommend that people talk to their clinician about the pros and cons of taking aspirin to see if that's right for them. We think on a population basis, there's a small benefit of taking aspirin, but there's room for individual considerations based on people's preferences in their own situations. Then, for people age 60 and older, we actually recommend against starting aspirin for the prevention of heart attacks and strokes. As one gets older, the risks of particularly bleeding, the main complication of aspirin, get higher. And the risks begin to outweigh the benefits. Now, I want to stress that this recommendation applies to people who are considering starting aspirin to prevent a heart attack or stroke. It does not apply to people who had a heart attack or stroke or other evidence of cardiovascular disease who are on aspirin, and people should not, who are already on aspirin, stop aspirin without talking to their trusted clinician about just being clear about the reasons they're on it and whether there are conditions they have that would benefit more from taking aspirin, like previous heart attack or stroke.
Okay, so that's pretty big news. If you're 60 plus and there's no reason for you to start taking aspirin, the task force recommends you do not start taking aspirin. And I think that's important because for some reason it's become urban legend that you should take aspirin to prevent a heart attack. And this is precisely why the task force is there, to chase down some research and figure out what makes sense. Do you think that people understand that science actually changes? Do you think that, are you often met with understanding about why there are new recommendations that might reverse older trends?
Well, you're absolutely right. As you mentioned in your introduction, science marches on. And we have much more evidence now in recent years, particularly for younger people under 50 and older people over 70, about the potential benefits and potential harms of taking aspirin. And that needs to be reassessed periodically, which the task force does. The background also changes, and I'll emphasize that in that aspirin is just one tool in the toolbox to try to prevent a heart attack or stroke. There are others, starting with a healthy diet and exercise, good blood pressure control, control of diabetes if someone has diabetes, and taking potentially a statin if people are at higher risk for a heart attack or stroke. And these days, with statins being so widely used, and with evidence that they are actually quite a bit more effective at reducing the risk of heart attack or stroke than aspirin, if you will, there's less room for reduction if people are doing all those other things. So aspirin is no longer the only intervention that should be considered when people talk to their clinicians about reducing their risks.
I like that. I like the idea that we have many tools in our toolbox because we all know that as we get older, things change and we have to be a little bit more careful and more aware of what we are doing and how it, the side effects. So the fact that you don't just assume that you know the answer, talk to your clinician and understand and get a real picture of what you can do, as you said, which I love, first of all, with diet and exercise, because I do think, a lot of the evidence shows that what we can do in our lifestyle positively impacts our health.
Indeed, that's the case. And people shouldn't get the idea that perhaps taking aspirin will obviate the need for regular exercise, a healthy diet, interventions that are shown to be effective in terms of prevention of many diseases.
Speaking of prevention, one thing that I have heard, and I'm sure you've heard it too, is that if exercise were a drug, every physician or clinician would write a prescription for it. Do you agree with that?
Well, exercise is really important and gets more and more important as one gets older. And I think talking to people about exercise and the many ways they can reduce their risks of heart disease and cancer, which is really important. It's a prescription that may be a little harder to fill. Can't just go to the pharmacy and get a jug of exercise. We actually suggest that about 150 minutes a week, at least, of at least moderate physical activity is good for you, and that's a prescription you sort of have to fill yourself.
Okay. Continuing to talk about prevention, one of your recommendations is for lung cancer screening. Can you tell us who you recommend that for and how does that work?
Surely. Well, lung cancer is our number one cancer killer in the United States. So really important to do whatever you can if you're at risk. And we'll talk about that to reduce your risk of dying of lung cancer. Before I get into our recommendation about screening, I'm going to stress that the most important thing someone can do to reduce their risk is if they're currently smoking to quit, and if they've already quit to stay quit. And that's the most important intervention. But we also know from relatively recent research that people who are at risk for lung cancer because of their smoking history can benefit from what's called a low dose CAT scan of the lungs, which can be done on a once a year basis to try to find lung cancers early when they're more treatable. Now, we recommend that people who are age 50 to 80 who have a particular smoking history that I'll go through, again, talk to their clinicians about getting an annual low-dose lung CT scan. Now, let's talk about that risk. First, current smokers or people who've quit within the last 15 years should think about lung cancer screening. And there's a particular threshold we recommend, which is having smoked at least 20 pack years of cigarettes. Now, what do we mean by that?
Yeah, I've not heard that term, 20 plus years.
Let me explain it. And it's what's been used in the trials that have shown that screening makes a difference. So if you smoke one pack of cigarettes a day for 20 years, that's 20 pack years. If you smoke 2 packs a day for 10 years, that's also, if we do the multiplication, 20 pack years. So the heavier you smoke, the shorter the time it takes to get to that 20 pack year threshold. So again, it's just an estimate, but helping as a clinician, helping people estimate the smoking history is important to make recommendations about a CT scan screening.
So before you go on, can you just, now that you've explained what a 20 pack year is, can you reiterate your recommendation?
So for adults age 50 to 80 who have smoked at least 20 pack years and are current smokers or have quit within the last 15 years, we recommend an annual low dose CT scan to screen for lung cancer.
That's very important. And I think that a lot of people would benefit from doing this because if you catch lung cancer early, it's more preventable.
Exactly. The studies suggest one might lower one's risk of dying of lung cancer 20% or so by following through with the low dose CT scans. And one advantage of lung cancer screening is we can really focus it on the people who most stand to gain based on their smoking histories. That said, this is a relatively new recommendation compared to, say, mammograms or pap smears, and as a result, still quite underutilized. So appreciate Seniority Authority helping us spread the word that we've got a new tool for reducing the risk of lung cancer deaths, in addition to quitting smoking or staying quit, the most important one, as I said before.
And for our listeners who want to read this recommendation more thoroughly, we will have the full recommendation in our show notes and a link to the task force site. Let's go on and talk about another critical screening recommendation that you have, which is colon cancer screening. Exactly what age should that happen? And is one screening enough? Is it one and done?
Not one and done, I'm afraid. But let's step back and just say now we're tackling our number 2 cancer killer across men and women. And this is one where the risk isn't tremendously focused on one group like smoking for lung cancer. It's really something applicable to folk age 45 to 75 who we think should be screened periodically for lung cancer. For colon cancer. And I'll explain what we mean by that. So it is not one and done. We had recently lowered the starting age from 50 to 45 with some evidence that colorectal cancer incidence is increasing among younger people in particular. Now, in addition to recommending screening for people 45 to 75 on a regular basis, we think screening can be considered selectively for people age 76 to 85, depending on patient preferences, the risk of complications, and their screening histories. Now, I'll come back to that in terms of how to be screened. And the good news is there are really lots of options that are effective for colorectal cancer screening. Many people have heard of direct visualization tests like colonoscopy, where a doctor uses a lighted tube to look through the colon. And colon cancer screening is really a twofer. It kind of works in two ways to reduce your risk of dying of colon cancer. One is you might find an actual colon cancer earlier when it's more treatable, sort of like the lung cancer story. But you can also find polyps called adenomas, which may be tomorrow's cancers. Polyps can evolve into cancers over many years, and those polyps can be removed and reduce the risk of even getting colorectal cancer in the first place. So again, a twofer. So one could consider doing a colonoscopy or another direct visualization test. There's a CT colonography that can be done to assess for cancer or polyps in the colon. And there are also other tests, indirect tests that could be considered, like stool tests. And there are several different kinds that need to be done more frequently. If colonoscopy is negative, usually the recommendation is repeating it in 10 years. Stool tests need to be done more frequently, every year or every couple of years, depending on the test itself. And as long as one picks a test that's right for them and does it regularly at the recommended intervals, they're all effective for reducing the risk of dying of colorectal cancer. So if someone is concerned about the risks of colonoscopy, and there are smaller risks of bleeding or even a tear in the lining of the colon, a small risk, they have the option of going with, say, a stool test. But if any test other than colonoscopy is positive, in other words, if there is evidence of blood in the stool, say, on a stool test, then it's important to follow up with colonoscopy to make sure that there's no cancer that needs treatment. So again, lots of choices, but ultimately it would be a colonoscopy test that makes the difference.
Okay, so that's a very strong recommendation. If you're getting smarter, help us reach more minds. Leave us a rating and review on Apple Podcasts. Tell your friends to follow us on social or subscribe to our newsletter at seniorityauthority.org. I want to just stop here and talk about the level of recommendations that the task force makes and how you rate them, because I'm sure some of our listeners are listening to this and thinking, okay, so I need to do the lung cancer screening and the colorectal cancer screening, and what is that going to cost me? Because as we all know, visits to the doctor can be very expensive. But with the task force, with the recent Affordable Care Act, the task force recommendations have different ratings. And in fact, some ratings are mandatory, covered by insurance. Can you talk a little bit about that?
Well, I should first say that the task force actually just looks at evidence on benefits and harms and doesn't look at costs in making recommendations about screening.
Yes.
You're right. The current law does say that for task force A and B recommendations, and I'll explain about those, that most insurers, at least most private insurers, need to cover them without copayments. And the Medicare program, the Medicaid programs make their own decisions about screening. So they're not part of that current law. But let me talk a little bit about the strength of the recommendations and A's and B's and that sort of thing. So an A recommendation is, if you will, our highest bar in terms of evidence. And we use two factors in making one of these letter grade recommendations. One is, after viewing the evidence, how certain we are that the evidence gets us to a good level of understanding the benefits and harms. And then we looked at the magnitude of the net benefits. And net benefits just means benefits minus harms. Colorectal cancer screening for folks age 50 to 75, it's actually an A recommendation. We have high certainty of a substantial net benefit. Now, B recommendation means that our certainty may be a little bit less, or the magnitude of net benefit may be a little bit less. But really, for practical purposes, A's and B's we recommend doing. And the distinction between A's and B's are fairly subtle. It's not important as far as the Affordable Care Act is concerned. A C recommendation means we're at least moderately sure there's a small net benefit, at least at the level of the population. And actually, the recommendation for considering aspirin for people age 40 to 59 is a C recommendation. We think there's a small benefit at a population level, but there's room for preferences to make a difference. And that's why we suggest people talk to a trusted clinician about whether that recommendation is right for them. If we actually come up with at least moderate certainty that there's no benefit to an intervention, or that it might do more harm than good, then we issue a D recommendation. Now, sometimes, more frequently than we would like, we review the evidence and find it's insufficient to recommend for or against an intervention, in which case we issue an I statement. We do not, unlike perhaps some other groups make recommendations, sort of fill in with expert opinion if there's not enough evidence to say. We issue a call for research that goes to our Congress and National Institutes of Health to try to fill in those evidence gaps when we identify them. So those are the different levels of recommendations. For practical purposes, A's and B's, we recommend clinicians and patients do them. For C recommendations, it's individualized, do them selectively. D's are recommend against, and I's, we just don't know. We need more evidence.
That's an excellent explanation. Thank you so much, Dr. Berry. And our listeners can go to the task force website and search by letter grade, which I have done. I would recommend that so that you understand what the really important suggestions are. And again, as Dr. Berry said, this is all evidence-based. This is not opinion. So it's nice to see that. And if you see an I rating, it probably means that more research is being conducted on that question. And these recommendations come out regularly. How often in a year, Dr. Berry, would you say you issue A and B level recommendations?
Well, we get together 3 times a year and issue recommendations. It depends on the year and the topic, whether they're A, B, C, D's, or I's. We like to revisit topics in general about every 5 years to see if there's been new evidence. And we keep our ear to the ground as far as being aware of new trials that are being done that might suggest that we look at evidence sooner rather than later. For example, in lung cancer screening, there was a large trial done in the United States that informed our first recommendations on lung cancer screening. But we were aware that there was another large trial going on in Northern Europe that, as it turned out, really reinforced those recommendations. And so we revisited that topic early, given that important trial.
That's fantastic. And one other aspect of healthcare that I think has changed in a lot of our listeners' lives in one generation is what's called shared decision making, or SDM. This is a shift from perhaps the 1950s, doctor knows all, to let's make a decision together with the information we have, which is a real change in the way we approach our clinicians. Can you tell us why that's important today?
Sure. Well, in fact, different people have different preferences, health situations, and it's important to consider not only the medical evidence that a clinician might be expert at, but also a person's individual situation and their values and preferences, which they're the expert at. And by sharing information from the clinician to the patient about what the options are and what the pros and cons of those options are, and the patient in turn sharing information with the clinician about what they really care about, is it is the way to get to better decisions. And actually, there's a good amount of evidence now, given that we're evidence-based, that approach can lead to higher quality decisions. My colleagues and I coined a phrase that maybe clinicians, in addition to the traditional question of what's the matter, should ask what matters to you.
Mm.
That's one way of summarizing the approach.
Well, I think that's interesting and definitely the future of healthcare. Does it open the door, just as a practitioner yourself, to everybody going to WebMD and pretending that they're an expert in the maladies that they currently have? Is that a little frustrating?
I actually think that you get better decisions when people are informed. Now, there are sources of information and misinformation. Our website certainly has information on the research that's been done on a particular preventive question. But, I think patients who are curious about their own health and what matters are, on balance, a good thing. And the more clinicians can signpost good information, I think the more helpful they can be. People still turn to their trusted clinicians for advice and information, and sometimes turn to other sources if they don't get it. And I think on balance, as in so many areas of life, an informed person can make better decisions.
Can you give our listeners an example of what shared decision-making looks like today?
Sure. Well, maybe let's go back to that aspirin recommendation. Remember, that was the C recommendation for age 40 to 59, where I might sit down with a patient who's getting into that age range or in it already and talk about, not narrowly necessarily about aspirin, but more broadly about what they can do to reduce their risk of cardiovascular disease, heart attacks and strokes in particular. So I'd want to know what they're doing for their health in terms of things like diet and exercise, maybe help them assess their risk of a heart attack or stroke. And there are algorithms to do so using factors like their blood pressure, whether they have diabetes, their age, their cholesterol levels, and then have a conversation about the options, the different ways they might reduce that risk through not only taking aspirin, but consider taking a statin, controlling their blood pressure better if that's up and they're on treatment, and then work their preferences into the decision about how best to proceed, and realizing that decision can be revisited over time as their situation changes. I've certainly had people who would want to pursue, say, a course of diet exercise for a mildly elevated cholesterol value. And if they're successful, then all the better. And sometimes, despite their best efforts, you might have to rethink that decision, consider a medication like a statin, which could be quite effective at reducing risk. But keeping the patient's preferences central in terms of, do they want to take an extra medicine every day, say?
Sure.
And face the, limited, but still important to consider potential side effects of any medicine, be it aspirin or a statin. And again, clinicians can sometimes assume that they know what people's preferences are. Sometimes we fall into the trap of thinking they're like ours, but they're not always. And you don't know people's preferences until you ask.
That is absolutely true. If our listeners wanted to become more informed about what they should do from a preventive measure to enhance their life, what would you suggest they do?
Well, our U.S. Preventive Services Task Force website, uspreventiveservicestaskforce.org, is a good place to go for information. We're also on Facebook if people like to access information that way. And we do, for some decisions, have a material specifically for patients that go through the options. For example, there are medications that can be used to reduce a woman's risk of breast cancer. And we have a conversation guide for patients and clinicians to talk through to help decide if that would be the right thing for them.
Excellent. Excellent. Is there one thing that you wish all of your patients did that would improve their health? I'd like to be very practical on this show. So we've got some really practical recommendations. And I love it because this is the new evidence-based research that you should do, the lung cancer screening, the colon cancer screening, the new recommendations on aspirin. But if there's one universal thing that you said, I'd love to see all my patients do X to improve their life, what would that be?
Well, rather than picking one recommendation we have and deciding that it's my favorite, that'd be hard for me to do. I think that concept of shared decision-making, of understanding that you can be a partner with your clinician and that your preferences matter in terms of what the right thing is for you to do. Be informed. Sometimes people will say, well, I didn't go to medical school or professional school. Why should I have a say in deciding? And, but the truth is that, while the clinician may be an expert in the medical facts and evidence, you are the expert in your preferences and what you care about. And by combining that with the medical evidence, that's how we get to better decisions. So that would be what I'd cheerlead about.
Okay. How long, just coincidentally, how long has shared decision-making been a trend, or when did this start? Because I think of the book Being Mortal by Atul Gawande, and that is very much in that ilk of what matters to you. So when did this new approach emerge?
Well, our group began a collaboration between Massachusetts General Hospital and Dartmouth up in your neck of the woods, have been producing decision support tools, decision aids to help people participate in decisions going back 30 years or more.
Wow.
So we've been pushing this boulder up the hill for quite a while. And, these days, shared decision making is on a lot of lips. It's getting into insurance coverage information. So it's gratifying for those of us who've been tilling the vineyard for a while.
Very nice to see that change during your lifetime. That's impressive.
Well, that's why I have to focus on my preventive care as long as possible so I can see the full evolution.
Absolutely. And now we are going to ask you a few questions about yourself. You're very, very smart in medicine, but we're going to get to know you a little bit better. Even though we've been talking about prevention, what is your guilty pleasure?
Well, I do have one martini on Friday night after a long week. I don't know if it's, that feels like moderation to me, so I don't feel so guilty about it, but I'll confess it.
Yeah, that is definitely moderation. What's your favorite personal healthy practice?
Well, given that fruits or vegetables are important, I do have 2 pimento olives in that martini, which I'm told is a fruit, not a vegetable, but both are important.
But very good.
More seriously, I'll just quickly say I am a step aficionado and get my 10,000 steps in a day without fail, which is probably a more serious answer.
Yeah, and it's not hard if you work at Mass General. Just getting from one area of the hospital to the other, you could probably get the 10,000 in.
Truth to that.
What's guaranteed to make you laugh?
Well, one of my favorite destinations, if I take a walk from work, is the nearby New England Aquarium, where there are harbor seals outside. And, the harbor seals are kind of swimming. They don't care much about what is going on in terms of human worries, of which there are plenty. They decide whether to swim right side up or upside down. And watching the kids watch them is always a smile producer.
What a great practice. That's awesome. Tell us about the last book you loved.
Well, I do audiobooks on those walks sometime. And I just finished the Aubrey Maturin series. This is a Patrick O'Brien series of historical novels.
Yeah.
About a British naval officer and his ship surgeon, who's also a British spy. And there are actually 20 of them. And just finished the last one. It's just wonderful. I love that series.
He's got he creates this swashbuckling world, that I love books that take us into a totally different universe. It's mentally wonderful. And when you're not on the deck with Patrick O'Brien, what is your favorite escape?
Well, I love Nauset Beach down in Cape Cod, which is not far away. It's just a wonderful place to walk and get the steps in.
Very, very nice. Well, thank you so much, Michael, for sharing with us all this really, really timely recommendation and for just letting our listeners know that the task force is out there and researching and doing work for them and how to find out more information, because I think understanding prevention is one of the best things you can do to live a longer and healthier life.
Agreed. And I'll stress that we have been talking about prevention, so that our recommendations are really for people who aren't having symptoms or problems. And if they are, then they should talk to their clinicians about them and get those sorted out. That would be what our recommendations would apply to.
Yep. We have an audience of pre-worriers and planners, people that like to think ahead. So I think you're talking to the right people. That is our show for today. If you enjoyed it, please tell your friends about us so we can reach more minds. Give us a rating and review on Apple Podcast. And send me your questions on aging. I want to know what's on your mind so we can track down the expert like Dr. Barry. Until next time, enjoy the chance to get smarter about growing older.